cho mẹ nè, con có phá mẹ luôn chưa?
Phá mẹ sao?
Đâu?
Hello everyone, good morning, good afternoon, good evening. A very warm welcome to the day 2 of this exciting motility masterclass with the renowned KU Leuven Institute in Belgium. With this, I would like to hand over to Professor TACK to take us ahead. Thank you very much.
Good morning and good afternoon to all of you. On behalf of my colleague Tim VANUYTSEL, who is a co-organizer of this masterclass, it is a pleasure to invite you to this Motility Masterclass second day from Leuven. You see here an image of Leuven taken at a sunnier moment than right now. Yesterday we had snow, today is a grey day, but we'll make the best with the presentations. The format is the same as yesterday. There will be presentations followed by questions. One thing is different compared to yesterday. I woke up with a very stuffy nose and it affects a little bit my voice and throat, as you may hear. What's on the program today? Irritable bowel syndrome, the first one. The second one, chronic constipation. Third one, chronic diarrhea. So we're really addressing the lower GI tract, whereas yesterday we focused on the upper GI tract. And a final kind of umbrella presentation on the use of modulators in DGBI. You have the occasion or the opportunity to ask questions in the chat, and we will address them after each lecture. The first lecture deals with probably the most prevalent condition in GI practice, the irritable bowel syndrome, which is, besides it's prevalent, a very exciting site of rapid developments pathophysiologically. In terms of treatment, the progress is slower, but you'll get a nice overview on the state of affairs and the clinical management of IBS by Dr. LUKAS Balsiger. LUKAS is a gastroenterologist in training who is performing research for a PhD here in Leuven at our unit, and the focus of his research is on IBS and especially on the role of food as a trigger and atypical food allergies in maintaining and triggering the symptom pattern. LUKAS, the floor and the screen is yours.
Thank you very much for this kind introduction. As Professor TACK has said, we will be talking the next 30 minutes about the diagnosis and management of IBS. We'll start with a brief case introduction, and this is a case you probably are all in some way familiar with. Emily is a 22-year-old university student, and she suffers from recurrent abdominal pain. This mainly comes as cramp attacks and is associated with diarrhea and urgency. And these attacks severely impact her quality of life, as the pattern of symptoms is unpredictable, and she's always afraid of the acute cramps, but especially of the urgency and the diarrhea. So her question in life every day is, where is the nearest toilet, and will I reach it in time? And I hope in the upcoming 30 minutes to give a bit of an overview how we can work up and further manage patients such as Emily. Irritable bowel syndrome is a disorder of gut-brain interaction, or formerly known as functional gastrointestinal disorders. As such, the Rome Foundation, in its fourth iteration of the criteria, has established symptom-based or clinical-based criteria to diagnose irritable bowel syndrome. So it's a clinical diagnosis. And the criteria put forward in the fourth edition of the Rome criteria is first and foremost recurrent abdominal pain. This pain has to be associated with 2 or more of the following criteria. It should be related to defecation, associated with a change in the form of stool, and or associated with a change in frequency of stool. The criteria should be present for at least 3 months, and symptom onset should be at least 6 months back. And it's important to note that the Rome criteria mandate that organic, systemic, or metabolic causes likely to explain these symptoms be absent. Now, an important side note for the clinical management of these patients is an addition that the Rome Foundation made with a statement put out last year. And they say that the duration criteria can be shortened when a clinician has evaluated the symptoms sufficiently and is satisfied that other diagnoses are confidently excluded. This means if you see Emily after 4 months of her symptom onset. You don't have to let her suffer for 2 further months in order to be able to diagnose her with IBS. So this was an important statement by the Rome Foundation endorsing a clinical management of these patients. When the diagnostic criteria are fulfilled, IBS is further subclassified according to the predominant stool type. On the left, you can see the Bristol stool scale we use to type the stools from type 1 to type 7. And on the right are the frequency thresholds. IBS can either be constipation predominant in predominantly constipated patients. We also call that IBS-C, diarrhea predominant or IBS-D, or mixed if both stool types are present. There's also a group of unclassified who do not fulfill criteria for any of the others. How frequent do we encounter IBS? Well, this is population-based data. So you can see the countries that have a color participated in this study and were people filled in questionnaires that actually represent the local population. So this is really population-based data. And overall of the world, 4% of the population fulfills criteria for IBS. You can see that the subtypes are more or less equally distributed between constipation, diarrhea, and mixed, and the unclassified subtype is rarer. 4% is population-based data, but you, from your clinical experience, and we know that in clinical practice, it is much more than 4% that fulfill these criteria. But it's a frequent disorder globally. And as we saw in the example of Emily, this disorder has an impact. Although it does not impact mortality, the health-related quality of life of patients is severely impaired. And it's similarly impaired to the health-related quality of life of patients suffering from asthma or migraine. Patients are more frequently absent from school or work, and this can be due to sick days, doctor visits, or leaving early because of the onset of symptoms. Besides the individual impact, it also has a big societal impact. Being so frequent in the general population, the costs to society are massive. In Europe, one patient is estimated to cost 2,000 euros per year. These are both direct and indirect costs. So it has a severe individual and societal impact. What causes then IBS, and what's the pathophysiology? Well, as Professor THÜC said, this is a domain of ongoing research. We don't fully understand the pathophysiology. It's likely multifactorial, and it seems likely that not every patient with IBS suffers from the same pathophysiological alterations. To give a very brief overview, I would like to talk to you about the central paradigm put forward here in a Rome Foundation publication from 2016. Besides other factors, the central paradigm of disorders of gut-brain interaction is the gut-brain axis. And you can see here that psychosocial factors such as life stress, psychologic state, but also coping and cognitions interact with gut physiology, with motility, sensation, with immune dysfunction, and they interact with each other in a bidirectional manner. And this is very important to understand. Both gut and the brain communicate in a bidirectional manner and influence each other, and this is why we term the disorders are now coined disorders of gut-brain interaction. What exactly do we know about the gut-brain axis in IBS? We know that these patients with IBS have altered brain signaling. When they receive a visceral stimulus, they have a higher activation of emotional connotated brain areas than healthy controls. Also, stress, and especially chronic stress, induces profound alterations on the gut physiology, alters motility, alters secretion, and alters permeability. From the gut upwards, we know that many of the patients suffering from IBS have visceral hypersensitivity. That means that a given stimulus in their gut will be more readily perceived as painful or uncomfortable compared to healthy controls. And playing a role in this visceral hypersensitivity, recent evidence has suggested local allergic reactions to food, but also local immune activation. And given this bidirectional communication of the brain and the gut, it's not surprising that we see a high rate of comorbid anxiety and depression in these patients. As a matter of fact, in a longitudinal follow-up study over 1 year, 1/3 of patients with anxiety and depression later on went to develop IBS, and 2/3 of patients with IBS or FD later went on to develop anxiety and depression, further reinforcing our notion of this bidirectional communication. How do we diagnose IBS then properly? I've mentioned the diagnostic criteria put forward by the Rome Foundation. And this is how every approach should start, with a careful history focused on key symptoms. We have to actively question the clinical criteria for IBS, and we should elicit triggering factors. Are symptoms food-related? Do symptoms occur more readily when the patient is stressed? We should do a focused physical exam, focusing on abdominal masses, lymphadenopathies, and this is especially important in constipated patients, a digital rectal exam. At this stage, we should also be prudent to exclude alarm features. I will not go through every single one of them, but important alarm features include that the symptom onset is above the age of 45 years old, rectal bleeding in the absence of hemorrhoids, unintentional weight loss, abnormal GI examination, and evidence of inflammation on blood or stool testing, as we will see later on in this presentation. So we've assessed the symptom pattern and we've done a good clinical history, we've done our physical exam, and we've excluded alarm features. The next step in diagnosing IBS is minimal diagnostic testing, and this starts with celiac serology. Why do we do celiac serology in these patients? We know from literature that patients fulfilling criteria for IBS are much more likely to have celiac disease. As a matter of fact, the odds ratio is 2.75 versus controls that do not have IBS symptoms. So this is a very simple test to diagnose something that is prevalent in this population, and it substantially alters our further management. Important, please always measure serum IgA if you use an IgA-based serology, as patients with celiac disease more readily have a selective IgA deficiency, rendering your test false negative. Furthermore, and this has to be actively questioned in the history part, the patient must be on a gluten-containing diet at the time of diagnosis. If the patient is not eating gluten at that time, this may also render your test false negative. The next step in minimal diagnostic testing is measuring fecal calprotectin and CRP. And this is, of course, to exclude inflammatory bowel disease or IBD. This is a systematic review from 8 years ago, and you can see in red the probability of patients, or the percentage of patients that have IBD. And you can see on the x-axis here the CRP level, and below a CRP of 0.2 milligrams per deciliter, IBD is virtually excluded. And the same goes for calprotectin. Again, in red, the percent of patients that have IBD, and on the x-axis, the calprotectin level. And you can see below a level of 40, IBD is virtually excluded. As a matter of fact, this stays pretty flat even to 100 micrograms per gram. And this is also the limit that has been put forward by IBD societies. And calprotectin below the level of 100 micrograms per gram is not suggestive for IBD, and further testing can be deferred. Important here is that you actively exclude the use of non-steroidal anti-inflammatory drugs, gastrointestinal infections, or other GI conditions that might interfere with your measurement. So we've established that the patient fulfills diagnostic criteria for IBS, we've excluded alarm features, and our minimal diagnostic testing is normal. But what about endoscopy? What about colonoscopy? Shouldn't we scope all these patients? This is data already 13 years ago now, where they looked at exactly that. More than 450 IBS patients and controls underwent colonoscopy. And you can see the lesions that we're afraid of, so polyps as precancerous lesions, were much more common in controls than in IBS patients. This is partly due to the age distribution, but reassuring nonetheless. There was a bit more mucosal erythema or ulceration in our IBS patients, but when they looked at it microscopically, IBD only was diagnosed in 2 of these 466 patients. Microscopic colitis was diagnosed in 7. So if we scope all the patients of with IBS, we see that here the diagnosis and thus the further management does not change in 98% of the cases, which makes it a very unattractive thing to do to a disorder, to do in patients with a disorder this prevalent. If we look at the distribution in patients that do have one of the alarm features that I presented earlier, this looks completely different. Although overall this is still low, we will go through what it was found in these patients. So these were patients that underwent endoscopy because they fulfilled one of the alarm criteria. Underlined in blue specifically are the IBS patients, constipation predominant, mixed, and diarrhea predominant. And you can see most alterations were found in diarrhea predominant patients. They found IBD, colorectal cancer, and microscopic colitis. And when we look at the age distribution, below the age of 45, IBD was the predominant feature in 85% of patients that had any alteration, colorectal cancer and microscopic colitis much rarer. Above the age of 45, this was almost equally distributed. And what's important is that the authors found upon chart revision that many of these patients that underwent colonoscopy, having IBS and alarm features, did not have any biopsies on colonoscopy. And of course, without taking biopsy, you can't diagnose microscopic colitis, which is the most common cause, the most common found alteration in the population above the age of 45 years old. So in a patient with alarm features, you can do a colonoscopy. The yield overall will still be low, but especially if the patient is above the age of 45 years, insist on biopsies to actively exclude microscopic colitis. When the authors then assessed which alarm features were especially associated with abnormal findings on colonoscopy, only 3 of the list I showed previously showed up. Was rectal bleeding, an abnormal GI examination, and raised inflammatory markers. So we've established that the symptom criteria are fulfilled. We've excluded IBD, celiac disease using minimal diagnostic testing, and now it's time for us to make a positive diagnosis. What does this mean? This means that with this workup in mind, we can confidently confront our patient and diagnose him or her with the diagnosis of IBS. We do not have to do any further testing. We do not have to communicate that we've not found anything and therefore it must probably be IBS. This would be the diagnosis of exclusion. We can positively diagnose this person with IBS. And we know that this is safe. 10 years ago, this study showed that one group of patients were positively diagnosed in the manner I just showed you. And another group of IBS patients underwent extensive endoscopic and biological workup to exclude any possible causes. That was named the strategy diagnosis of exclusion. And after 1 year, these groups did equally well in terms of symptom severity, health-related quality of life, and treatment satisfaction. After 1 year, and also in the follow-up after 5 years, there was no misdiagnosis using the positive diagnostic approach I just presented to you. Importantly, the diagnosis of exclusion, doing the extensive workup, was $900 more expensive per patient than the positive diagnostic approach. A diagnosis is only useful if we can then treat the patient. So how do we approach therapy in this population? Well, it starts with you and your relationship to the patient. You can see here on the y-axis the number of return IBS visits, the number of times a patient returns to clinic for their IBS symptoms, and on the x-axis the strength of the physician-patient interaction. And you can easily appreciate that the stronger the interaction, the less the patient requires follow-up visits. And this was mainly due to psychosocial history taking. So if the physician had a good psychosocial history, the patients had required much less follow-up visits than if he did not. Same went for discussion of what the diagnosis is, what the further management is, but reassuring the patient, merely saying this is not something life-threatening, merely reassuring the patient had no effect in reducing the return visits. The next step, and I think this is often overlooked, is what I call traditional advice. Others have called this the NICE diet. And these are guidelines put forward by the British societies, and on the nice.org.uk you can consult the full guidelines, but I would like to focus on the lifestyle and diet part. This is something that every IBS patient should hear. If they have a limited physical activity, they should be encouraged to engage in moderate physical activity. They should be encouraged to do minor diet and nutritional adaptations, regular meals and taking time to eat, drinking at least 8 cups of fluid, restricting the intake of tea, coffee, alcohol, and fizzy drinks, and limiting the intake of high-fiber food and fresh fruit. This sounds very simple, but we know that this works. On the left, in the y-axis, you have the IBS symptom severity scale ranging from 0 to 500. And here you can see the follow-up. And this is a head-to-head trial comparing the low FODMAP diet to the traditional IBS diet. And you can see that over 1 month, both are equally effective. So this is an easy to implement intervention. When it comes to pharmacological treatment, we distribute this according to the predominant symptom we would like to treat. And in case of diarrhea, there is one drug that has been on the market for a long time, and it's the mu opioid antagonist loperamide. This is not a study from 2015, but from 87. So this is very old data. And you can see here at baseline compared to loperamide, there was a reduction of diarrhea and urgency, but there was no reduction in pain. So loperamide works well for these two symptoms, diarrhea and urgency, but has no effect on pain. A potential treatment targeting several of these symptoms at once is the low FODMAP diet. What are FODMAPs? Fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And you can see here on the right examples. So fructans, for example, are contained in the Western diet, mostly in wheat products. Lactose, of course, in dairy products. Fructose in excess of glucose is contained both in fruit products, honey, but also in high fructose corn syrup. These FODMAPs have in common that they are poorly absorbed in the small intestine, and they reach the large intestine largely undigested. This induces an increase in osmotic pressure in the luminal GI tract, increasing water delivery. Our microbiome will start fermenting these sugars, leading to increase in gas production, and together this will lead to altered motility through luminal distension, and this will lead to the symptoms we are well aware of: pain, distension, diarrhea. Now remember the list of all the foods that I showed you: wheat, dairy products, fruits, honey. If we exclude all these high FODMAP diets from the diet, this has a good effect on symptoms. This is a very recent meta-analysis pooling data from several trials, and you can see that the low FODMAP diet has a good impact on global symptoms, on pain, and on bloating. However, there's a word of caution here. The low FODMAP diet should always be guided by a trained dietitian. The FODMAP diet intervention starts with 2 to 6 weeks strict exclusion, and this includes many staple foods, wheat, dairy products. And in case of a response, so after 6 weeks, if the patient had a symptomatic improvement, these products, these FODMAPs, should be stepwise reintroduced. And the goal is to identify which FODMAPs trigger symptoms in which patient, and the goal is to establish an individualized treatment or diet. In case the patient does not improve, the dietary intervention stops. It's important to note that the data I showed you in the meta-analysis is largely based on the strict exclusion phase, and we do not really know the long-term effects of a strict exclusion phase. It's likely that there will be some nutritional deficiencies induced with a diet that restrictive, but also some signals for microbial alterations that are rather harmful. So this really belongs in the hands of trained dietitians. Something that mediates a bit this exclusion diet and the need for dietitian support is this app-based intervention pioneered by or developed by our group and published last year in Gut, and this is the Domino app. This is a FODMAP lowering app that can be administered by the patient themselves without any dietitian follow-up. And you can see that here is the symptom improvement. It was more symptom improvement than typically used antispasmodic in Belgium in these patients. So this is highly effective, currently only available in Belgium, but definitely something to look out for in the future. Probiotics is something I would like to mention because it's very prevalent in the lay press and patients often wish for this treatment. And this is a messy slide by design. This is a meta-analysis of all probiotic data. It's already a couple of years ago. This section covers various combination probiotics, and these are single strains that are looked at. And overall, the meta-analysis concludes that probiotics have an effect. However, there's a huge variability in the quality of these trials, the species, strains, and combinations, the doses, and the delivery forms. And therefore, the American Gastroenterology Association concludes that interpreting the existing literature is problematic because of small studies, the multiple types and strains of probiotics, the inconsistent benefits on individual symptoms, and the lack of rigorous trials. So overall, as a group, they seem to be effective, but further research is needed to better identify which probiotics are effective in which patient. Antispasmodics and peppermint oil are treatments typically directed at pain. This is a trial using otilonium bromide, and this is an antispasmodic frequently used in Belgium. You can see here on the y-axis the decrement of a symptom, and you can see that otilonium bromide leads to a better symptom improvement than placebo, both in the frequency of abdominal pain, bloating and meteorism, and in global efficacy. However, and this I've highlighted in red, this is a rather late effect. So do not expect miracles with this drug. This is 12 to 15 weeks of treatment 3 times daily with otilonium bromide. So they work, but do not expect an immediate effect. Whether or not this translates to all antispasmodics equally, I cannot say, but for otilonium, this is definitely the case. Peppermint oil, this is a meta-analysis looking at evidence for peppermint oil, and peppermint oil is effective for global IBS symptoms and abdominal pain. Be very careful to inform your patient of the adverse event that is consistently reported, and that is heartburn. antidepressants or neuromodulators, and this is something that Professor VANUYTSEL will go in detail on. I will just briefly mention one trial on the tricyclic antidepressants, specifically amitriptyline. This is a very recently published paper, and these are patients with IBS in primary care. They were randomized to amitriptyline or placebo, and this is what I find very interesting about this study. They started their treatment on 10 milligrams of amitriptyline, and they were allowed to up-titrate up to 30 milligrams following this flow chart. So patients up-titrated by themselves at home. If there was insufficient reaction or insufficient response to the therapy, absence of side effects, they were allowed to up the dose from 10, 20 to maximum of 30 milligrams of amitriptyline. And this worked very well. This was not only safe, but 36% of patients reported considerable or complete relief of their IBS symptoms, and this was significantly superior to placebo. So something that we can easily prescribe in our clinical practice, and that has been proven to be safe and efficacious. A very brief word on constipation, which will also be addressed in much more detail later on. Polyethylene glycol as an osmotic laxative increases the frequency of bowel movements per week, but has no effect on pain. By contrast, lubiprostone and linaclotide have an effect both on pain and on bowel movements. With that, I thank you for your attention. I hope I've given some overview of how to manage your MLEs of the future, and I'm happy to take any questions.
Thank you, Lucas. So to the audience, you can send your questions in the chat, and we will start off with someone. So you alluded to the use of endoscopy, limiting it to selected groups of patients. However, there could be a reassurance effect of colonoscopy also in people who are younger, for instance, and worried or anxious about their symptoms. Is there any data on how useful it is to do endoscopy for that purpose, reassuring we looked very well and we saw nothing?
Well, that's a very, very good question and often a point of debate. There is very good data on the effect of reassuring the patient, where they compared IBS patients who had never had a colonoscopy, had a recent colonoscopy, or had a colonoscopy more than a year ago. And in terms of reassurance, these patients were all equally reassured. So in every of these groups, whether or not they had ever received a colonoscopy, 2/3 approximately were reassured. I'm not aware of how reassured the gastroenterologists are, if there's effect on the physician, but we know that for the patient, this does not help the reassurance rate.
Thank you. So with the focus on food lifestyle actually comes into the picture, and the low FODMAP diet is a complex one. The NICE guidelines seem a little bit non-specific in a way. If a gastroenterologist would like to give a short dietary advice in 3-4 sentences, what do you think might be useful to tell to a patient in case or without the case that you would later send them perhaps to a dietitian for a more in-depth approach? Is there anything short-term that they can do in terms of diet or that you are thinking of? I mean, some people say, I will avoid lactose. Some will say, I will avoid gluten. Any suggestions?
Well, I think most of these self-identified triggers are very difficult to reproduce if we do placebo-controlled interventions. These self-declared sensitivities often are not reproducible if we administer that food. So, for example, if someone says, I'm gluten sensitive, and we give gluten in a blinded manner frequently, this is very difficult to reproduce. I think the NICE guidelines are very, I agree, they're not very specific, but the fact that they work in controlled trials for me suggests that these patients need to hear it at least once in their career of having IBS. And for me, I personally memorize the NICE guidelines as the tips my grandmother would give me. Take your time to eat. Don't leave too much time between meals. Chew well. Don't drink too many fizzy drinks. And I think, although this might not be the silver bullet for the patient should hear it at least once in their career that this can improve their symptoms.
Okay, so while we're talking diet, the FODMAP diet is maybe vested very much on the Western lifestyle and diet, and I think the vast majority of studies are coming from the Western world. Do we have any idea whether this is an issue in other parts of the world, or does this need to be studied, or are there reasons to think, well, this will be a mainly Westernized approach and will not help in non-Western situations or social environments?
That's an excellent point. To be honest, I'm not aware of a FODMAP exclusion diet study in an Asian context, for example. One can easily imagine that the fructan intake, for example, would be much lower in a rice-based diet than in our Western wheat-based diet. I'm not aware. You might be better aware of the studies there, but I would certainly not be hesitant to generalize this to everyone worldwide.
To my knowledge, it's really understudied. I also think what you said in terms of the wheat base, which is dominant in the West and different in Asian countries, that's certainly a valid remark. There's one study from Hong Kong who has shown some benefit of the low FODMAP diet, and the Hong Kong kitchen is very, very international, but probably not classically Western. So maybe the potential is there, but it's the only thing we have ever seen from Asia so far published in the literature. There's a question also from the audience: how long to advise the patient with a low FODMAP diet, and how to reintroduce the FODMAP diet in the IBS patients? And is it also helpful in IBS-C? So how long, the reintroduction phase, and does it also help the IBS-C? 3 questions in one sentence.
Yeah, so how long the exclusion phase should be between 2 and 6 weeks. The reintroduction, I'm not familiar with that because this is done by dietitians here, how long that specifically takes, but this will take at least another 12 weeks to sequentially reintroduce these foodstuffs. And is not very easy. I've had professors of orthopedics write me emails to advise them how to reintroduce this. So this is very difficult to really introduce in your daily practice. As far as IBS-C goes, most of these studies look at IBS globally, and there was an effect as well on constipation predominant, although probably less prominent.
So, if I'm not mistaken, one of the FODMAP studies gave patients in Australia the food during 3 weeks, FODMAP rich, FODMAP low, and there the patients benefited, and they had a group of healthy volunteers who were also exposed to both type of diets, and there was no difference or induction of symptom in the healthy volunteers in the FODMAP rich diet that they received. What does it mean? How can we explain this? Because the osmotic effects of fermentation you showed, they seem like kind of general.
I completely agree. And this has been reproduced in other studies where they've administered fructans in patients in the MRI. And they've actually seen that in healthy and in IBS patients, the osmotic effect, so the thickening of the small bowel, was exactly the same in both groups. However, only the IBS group developed symptoms. So probably it goes in the direction of the gut-brain axis, with actually visceral hypersensitivity, where the same stimulus luminally is perceived much more uncomfortable or painful in the IBS population.
So that would point towards visceral hypersensitivity. On the other hand, and the osmotic effects would certainly fit in that hypothesis. On the other hand, the fermentation can be gut flora dependent, and there have been some, let's say, victory reports of using fecal microbia transfer or transplantation in patients with IBS. What do you think about that? Is it ready for prime time? Can you consider it in a difficult patient, or should we keep distant?
Well, it's certainly not ready for prime time. I think there's some studies from Norway that reported success rates around 80%, which is simply too good to be true, if you ask me. There are some meta-analyses confirming a beneficial effect, especially if you administer fecal microbial transfer endoscopically. However, these are also heavily driven by this trial. And we know that this trial used a super donor. So they had one super donor with extremely favorable composition. There are, I checked just today, there are ongoing 29 studies registered on clinicaltrials.gov for FMT in IBS. And I think we should await the results of these studies and not apply this in clinical practice just yet.
Okay, fully agree. Last question, maybe a difficult one, but it is about lifestyle as well. The prevalence of IBS seems high, and it seems to be rising. Maybe this is awareness or not, but is there any evidence that a sedentary lifestyle predisposes to IBS and that exercise improves it? Any idea whether you can recommend that to a sedentary IBS patient with the hope of gaining something in terms of symptom control?
I'm not aware of epidemiological data. There are some data from Spain where gas mobilization was clearly improved with moderate physical exercise as compared to just sitting down. So especially for bloating, we do have some mechanistic evidence that moderate physical activity will help. And I think the guidelines and the NICE guidelines suggest that if you have no physical activity whatsoever, you should at least introduce moderate physical activity. And again, I don't think that this is the silver bullet that will solve all the problems, but I think really sedentary lifestyle will globally benefit from introducing some form of moderate physical activity.
Thank you very much for the excellent presentation and the excellent responses to the very varied questions, I guess. And now we will move to the next section. We stay in the bowel and we focus on chronic constipation. Has already been announced that this is one of the topics. And the speaker is Tim VANUYTSEL, my colleague here in Leuven, who doesn't need an introduction. You already saw him present and interact yesterday. And Tim, you have the screen.
Thank you very much, Jan. So after a great talk of Dr. Balsiger on irritable bowel syndrome, I will now focus on one of the symptoms or the possible symptoms of IBS, which is constipation, which can present itself as constipation predominant IBS or functional constipation, and we will highlight the differences and how this can be diagnosed and treated. So constipation, just like IBS, is not a rare condition. This is a meta-analysis of the published literature, where you can see that following the Rome 3 and the Rome 4 criteria, which are very similar, the prevalence worldwide is about 7%. If you pool all the data on constipation, not necessarily following the Rome criteria, this is about 1 in 6. Similar to other disorders of gut-brain interaction, there is a female predominance with an odds ratio of about 2.2, similar to IBS, similar to functional dyspepsia. Out of all disorders of gut-brain interaction, communication is most key, I think, in patients with chronic constipation, because there are a lot of misunderstandings. It's easy to go on a wrong path in terms of communication, and so you have to make sure that you understand exactly what your patient means when he or she is discussing her symptoms of constipation. Because we as physicians, when we think about constipation, for us it's obvious it means that there are infrequent stools. However, it can also just refer to the consistency of the stools, not necessarily to the frequency. Or it can mean that the patient has to strain in order to evacuate the stools, a sense of incomplete evacuation, the need for manual maneuvers like a pelvic support or the digital evacuation of the stools from the rectum, a feeling of blockage, and so on. So all of these symptoms can be part of the realm of chronic constipation, but of course their management can be different. So make sure that you understand what your patient is saying. This is the Bristol Stool Form Scale, and this is a very useful tool to use in your outpatient clinic. We use it every day, and we ask our patients to indicate what do they mean with hard stools or what do they mean with constipation. And by definition, the type 1 and the type 2 stools, like the bullet form stools, is type 1, and the bullets clumped together is a type 2 on the Bristol Stool Form Scale. This is by definition constipation. I prefer to ask patients to indicate this on these drawings of the Bristol Stool Form Scale rather than a novel trend that we sometimes see that patients are sending us their pictures, which we really want to avoid. Other things that you need to address in your outpatient clinic is whether you need further evaluation. Do you need an endoscopy? Well, not always. It depends on alarm signs and symptoms, as I will show you. You need to make a decision whether this is a case of primary constipation, so no underlying cause, or secondary constipation, for example, due to medication. What was the timing of onset? Is this an individual who has suffered from constipation all of their life, even already as a baby? Maybe pointing you towards a congenital disorder like Hirschsprung's disease, which may not have been recognized as a child, or did it come up as an adult? Was this related to stressful events? Was this related to starting of the menstrual period, and so on? Was the onset associated with start of any medication, for example, or with childbirth? All of these can point you in a certain direction. What is the amount of fiber intake? Are they not taking in enough fiber? Or on the other hand, are they eating so much fiber that they may feel bloated and they may feel distended? We often see this in clinical practice as well. And is there a history of psychological, physical, or sexual abuse? I put it between brackets, not because it's not relevant, it is, and it has been estimated that about 1 in 6 individuals suffer from a history of abuse. But of course, it's not easy to address this already during your first outpatient clinic, but keep it at the back of your mind and make sure that it is being addressed at some point. So patients who are losing weight, patients above a certain age cutoff, and it is being put earlier and earlier. So age above 45 years old is now used as a cutoff. Blood mixed with the stool, not from hemorrhoidal cause. Presence of anemia. Symptoms at night, especially abdominal pain in that case. Family history of colon cancer, IBD, and I would add celiac disease there as well. And the relevant abnormalities on physical examination. All of these are red flags, which will push you to do some additional tests, including in colonoscopy. So looking at primary versus secondary constipation, the first and most important thing to consider is constipation as a complication from medication. Number one, of course, opioids. Opioid-induced constipation is prevalent and is important to recognize early on. But other drugs can cause constipation as well, like anticholinergic drugs. Antidepressants can have anticholinergic side effects leading to constipation. Iron supplements, anti-epileptic drugs, or antiemetics, like, for example, ondansetron. And this is something actually that we use in clinical practice to treat diarrhea, which will be discussed by Professor TACK in the next lecture. So opioids can cause a whole array of problems. In general, all of these are combined as opioid bowel dysfunction, or OBD, and this is a combination of nausea, anorexia, vomiting, constipation, abdominal distension, and so on. But within the opioid bowel dysfunction, there is the big cluster of patients suffering from opioid-induced constipation, and about 1 in 3, 4 out of 10 individuals will suffer from constipation once they start on narcotics. And then there is a more rare condition, which is called narcotic bowel syndrome, or NBS. I will not go into detail, but this is a paradoxical increase of abdominal pain while patients are being treated with opioids. is probably related to activation of glial cells, which are an immune cell type that will support the neurons. When they are activated, this can lead to neuronal activation and leading to paradoxical increases in pain while being on opioids. An enigmatic condition, but important to recognize. And the treatment in that case is not to increase opioids, but to wean patients off opioids during a structured program in hospital. But so in terms of opioid-induced constipation, what we should be trying to do is to block the adverse effects in the periphery, i.e. in the GI tract. So opioids work by activating a mu receptor in the central nervous system. This is the analgesic effect, and they cause their side effects by activating the same mu opioid receptor at the level of the colon, small bowel, stomach, and so on, leading to reduced motility, reduction in secretion, and also elevating the tone of the anal sphincter, also contributing to constipation. One way around this is to use what is known as a pamora. And pamora is a peripherally acting mu opioid receptor antagonist. So this will then lift the side effects from the opioids in the periphery, but these pamoras, they cannot cross the blood-brain barrier, and thereby the analgesic effect will be preserved while ameliorating the peripheral side effects, including opioid-induced constipation. And one of the most recent ones is naloxegol. Naloxegol is one of these pamoras. So this is a phase 3 study published in New England Journal of Medicine about 10 years ago already. And 2 doses of naloxegol once daily were tested for 12 weeks in patients who were on opioids for non-cancer related pain and suffered from opioid-induced constipation. The primary endpoint, and these were 2 phase 3 studies combined, the primary endpoint was the achievement of having at least 3 complete spontaneous bowel movements per week, with an additional complete spontaneous bowel movement per week, at least 1 compared to baseline. And this should be present for the at least 9 out of the 12 weeks of the study and at least 3 out of the 4 final weeks. This is a standard FDA endpoint for chronic constipation. And you can see that both of the doses of naloxegol, 12.5 and 25, were superior in achieving this endpoint in comparison to placebo. So if there is no sign that the constipation is secondary to another condition or to drugs, then this is probably chronic functional constipation according to Rome 3 or Rome 4 criteria. These are the Rome criteria, the Rome 4 criteria, and you can see that they are a bit more complex than what we are used to see for other conditions like IBS or functional dyspepsia. And this is necessary because it really reflects the different phases of the functional constipation. So it includes straining, the presence of hard stools, bristled stool from scale 1 or 2, as you can see on the right, the sensation of incomplete evacuation, a sensation of blockage, and the need for manual maneuvers. And all of these 5 that I mentioned should be present in at least 1 out of 4 bowel movements, combined with the fact also that there should be less than 3 spontaneous bowel movements per week. This is another criterion. It should not necessarily be there, but it's one of the 6 criteria. Then there should be a rare occasion of having loose stools. Of course, you can have some overflow diarrhea, but it should not be prominent, and they should not fulfill criteria for IBS. Difference between functional constipation and IBS is that in patients with constipation predominant IBS, the predominant symptom is pain, while this is much less prominent in functional constipation. But of course, it is a continuum. Patients can shift from one condition to the other one over the course of time. The first step in chronic functional constipation, as you can see in this algorithm, dating back from Rome 3, but it is still very similar to Rome 4, even if it is the same, is education, lifestyle, and dietary measures. And the one measure that we always think about is, of course, to increase fiber. And fiber will aid these patients. What will happen is by eating fiber, which is an undigestible carbohydrate, you will bulk the stools. And by bulking the stools, you will accelerate transit time. These fibers will be fermented in the colon by the microbiome to short-chain fatty acids, butyrate, propionate, and acetate. This will increase the osmotic load, attracting water into the lumen of the colon, again, accelerating transit time, improving the consistency of the stools, making them softer, all contributing to improved symptoms. And by the beneficial effects of these short-chain fatty acids to the microbiome, you will also have an improvement in your colonic microbiome. That's a good side of things. This is indicated in green as well. However, by fermentation, there will also be a production of methane, hydrogen, and carbon dioxide gas. And all of these can lead to pain, bloating, and flatulence. So this means that there is a so-called fiber paradox. So patients can be helped with using fibers. However, when you eat too much, you will feel bloated and you can have problems. But having said this, soluble fibers, like for example, psyllium fibers as a supplement, can be helpful in functional constipation and in constipation predominant IBS. Remarkably, there are almost no data on increasing the fiber content of the regular food, almost no data. A recent study that I think is quite interesting is a comparison between the intake of fiber from soluble fibers psyllium, 7.5 grams, versus eating 2 green kiwi fruits. This is a study, not a surprise, comes from New Zealand, where these two have been compared in a crossover design. And there were 2 treatment periods, 4 weeks each. So one group had psyllium first, then there was a washout for 3 weeks, and then crossed over to the kiwi fruit, and the other group did the alternative trajectory. The outcome was assessed at the end of each 4-week treatment period. There were also some healthy individuals included besides functional constipation and constipation predominant IBS. What you can see in this graph is the change in the complete spontaneous bowel movements per week. So you see here that also in healthy individuals on the left, there is an increase of about 1 spontaneous bowel movement per week, both with psyllium and kiwi fruit. And the same is true for functional constipation and constipation predominant IBS. But in the 2 patient cohorts, it is clear even if it is not significant, that with the kiwi fruit there is a better effect if you compare to psyllium. And if you combine the 2 constipated cohorts, this reaches statistical significance. So this has changed my practice. And while I was prescribing a lot of these soluble fibers, psyllium, I now introduce this study, the concept that actually eating 2 kiwis a day may be as effective and much more pleasurable, I think. Next step is to use laxatives. The main ones are osmotic laxatives, which will attract water by their osmolar load, versus stimulant laxatives, which will increase the motility of the GI tract, where there are the diphenolic laxatives, where basacidil and sodium pycosulfate are the 2 common classes, and the anthraquinones like senna. Magnesium oxide is classified as an osmotic laxative, but it also will have stimulant effects on the colonic contractions. A recent meta-analysis looking at other food supplements as well, showing you that 2 studies combined, there are not many studies here that are randomized, shows that both in terms of frequency and consistency, magnesium oxides 3 to 6 grams per day can be helpful. And the same is true for osmotic laxatives and stimulant laxative. And this is also confirmed in the latest guidelines of the American Gastroenterological Association, the AGA, where the use of osmotic laxatives like PEG or macrogol is recommended. Same is true for magnesium oxides, and the same is true for lactulose. Stimulant laxatives, they are recommended, but only for short term, and this is defined as a treatment period of 4 weeks or less, or as rescue therapy. And this is usually how we do it. We use the sodium pycosulfate or basacidil as a rescue therapy if they haven't had stools for a couple of days. Or what we also sometimes do is to give it not on a daily basis, but as an add-on treatment once every other day or every 3 days to improve the stool pattern. Lactulose is a semi-synthetic disaccharide, which looks very much like lactose, but the difference is that the lactulose, which has a 5 ring in the second position cannot be hydrolyzed by disaccharidase, and so therefore it cannot be split into the monosaccharide moieties and it cannot be easily absorbed. So it is inert, it's not absorbed, and it has an effect on the stool consistency by attracting water. It is an osmotic laxative, but beside this, it is also a prebiotic, meaning that it can be used as a substrate by bacteria, leading to production of short-chain fatty acids, which is effective for patients with constipation. It has an osmotic load as well. The downside, as we discussed, is that in some patients, it may lead to bloating, abdominal distension, and flatulence. There is a prebiotic effect of lactulose. This was a comparison between patients using lactulose for 1 month in light gray versus macrogol or PEG in dark gray for 4 weeks. And you see that there is an increase of bifidobacteria with lactulose, while there was a decrease with polyethylene glycol. So it is useful to use lactulose in patients with functional constipation, but it takes a while until you have the optimal effect because of its prebiotic effect on top of the osmotic effect. This is an internet-based survey from 10 European countries, all with self-reported constipation, 1,355 individuals. And in this survey, 2/3 of patients were actually taking laxatives. This is already remarkable. 1/3 of individuals will not take any therapy for the constipation. And you see the divide between the different laxatives, where in Belgium and the Netherlands, most of us will use the polyethylene glycol or macrogol, where in other countries, anthraquinone in Italy and Spain, for example, is more popular. But more remarkable is that only 1/3 of the individuals taking medication was actually satisfied or very satisfied with their therapy. So in many individuals, you see here 1/3 is dissatisfied or very dissatisfied and 1/3 is neutral. In many of the individuals taking these laxatives, they do not feel helped by osmotic and stimulant laxatives. So the next step is to switch from a conventional laxative to an enteroprokinetic drug like prucalopride. Prucalopride is an agonist of the serotonin 4 receptor, which is involved in the peristaltic reflex. This is a schematic representation where the stools or any type of distension in the gut will activate neuroendocrine cells. This will
after I went. You can qualitatively confirm this by a Sudan red staining, but there are more sophisticated ways, as I will show you in some of the next slides. So we want to know, when did the diarrhea start? Has it always been there? Did it gradually occur, or was it very suddenly? If it's suddenly, we will still be thinking of chronic infections as a trigger. Additional symptoms. Is there abdominal pain? Is there weight loss? Are there autonomous symptoms? Is there any suggestion of dumping syndrome? I will not go into that, but this is diarrhea with a very, very pronounced faintness feeling, with sweating very often after surgery to the upper GI tract. And is there flatulence, distension, or bloating? And how does the stool look? And you really need to talk about stool aspect, volume, color, and behavior in the toilet. Is the stool continuously or intermittently diarrheic? Is it a large or a small stool quantity to the patient? But patients will tend to overestimate the volume. How frequently is it a day? Is it at night? Is there a urgency with it? Is there tenesmus, the intention to go and then cannot evacuate? This is more likely with a functional type of diarrhea. Is there any blood in the stool? Is there mucus? That would suggest an inflammatory cause. However, mucus can be non-specific sign of bowel irritation. Is it related to food? And is it fatty, sticky? That is steatorrhea in that case. What is the patient taking in terms of medication? NSAIDs can drive through, especially small bowel inflammatory lesions, can drive diarrhea. The sartans can drive diarrhea by mimicking, inducing a celiac disease-like picture in the bowel, in the small intestine, in those who are susceptible to it. Antibiotics, of course, can trigger diarrhea, either by changing the bacterial flora, or in the worst case, by allowing C. diff to emerge, but these patients will really be sick. Metformin is a classical cause of diarrhea in the diabetic type 2 patients, and some chemotherapies, and of course magnesium salts, for instance, if taken in high quantities as in antacids, can also drive diarrhea. And alcohol is diarrheagenic. Coffee is diarrheagenic. Sweeteners, including those with sorbitol, can be diarrheagenic, and some food constituents can cause diarrhea. They have been mentioned to some extent in the treatment of constipation, but if you eat enough rhubarb or prunes, everybody will get diarrhea. And is there a family history and a recent travel to places where parasites or chronic infections, amoeba enteritis, for instance, could be prevalent? Then we do a clinical exam, and the rectal exam can show you blood or pus in the stools. You want to evaluate for inflammatory signs in the blood. You want to check for proctological abnormalities, indicative of a Crohn's disease that might be present. Signs of obstruction clinically, palpable abdominal mass, and then ask about generalized symptoms like weight loss, fever, and in blood tests, anemia, iron deficiency, and I already mentioned extraintestinal manifestations and signs of malabsorption, which will usually be in the blood works, except when it's really, really very pronounced, people developing a cramp or a spasm of the arm when you do a blood pressure measurement, but this is very, very, very rare. It's in textbooks, but you hardly ever see this. So functional diarrhea and IBS, together with IBD, are the ones to keep in mind. And diarrhea in the functional bowel disorders is on a continuum. You have functional diarrhea if there is no pain, and you have IBS with diarrhea if there's a lot of pain. And the treatment to some extent will overlap. We can use some IBS drugs for functional diarrhea, vice versa. We can use some functional diarrhea drugs for IBS with diarrhea, but dosages may be adapted perhaps, and there are some slightly different choices based on whether pain is present or absent. The Rome 4 global epidemiology study has looked at the prevalence of IBS according to the Rome 4 criteria in like 77,000 subjects worldwide. And that shows an overall prevalence of 4.9% of IBS, 1/3 of them more or less diarrhea. This is somewhat of an underestimation because there are weaker forms of IBS where there's less pain, more discomfort, that may bring you up to 7-8%. And in the same study, so you see here the IBS prevalence, you also see the functional diarrhea prevalence. And on a global scale, this is 4.7% of the population. Paradoxically, this is one of the few exceptions. Males are slightly less prone to have chronic functional diarrhea than females, 5.3% versus 4.1%, and there is no clear-cut tendency with age. It continues to fluctuate around 4.5% according to the age span. So chronic diarrhea, not rare. Initial testing after history taking and clinical exam, we look for tests showing inflammation in the blood, so full blood count, CRP. We look for malabsorption, that will be anemia, but we also look at vitamin levels and micronutrient levels. We take an iron status, and we exclude celiac disease by serology. And you can do a TSH for thyroid function. However, the yield is very low in typical diarrhea. The cost benefit has not been fully demonstrated, but I do it always in the patients with diarrhea that I see. And then already, as alluded to by LUKAS, fecal calprotectin is really the key test to orient yourself whether this is a worrisome stool pattern in terms of underlying inflammation or a reassuring one in terms of the absence of inflammation in the bowel. And in patients with a circumstance or an origin or a recent visit that makes it eligible, you could consider parasitic infection. Less prevalent in our parts of the world. We do have Giardia, but there's many in people who travel exotically, and this is increasingly done. And then C. diff, of course, in somebody who had recent antibiotic intake, but that is a different picture than chronic diarrhea. These patients are often also systemically sick. So the fecal calprotectin, you've seen this one, the cutoff, we do not really worry below the 100 micrograms per gram calprotectin in the stool sample. And this mainly excludes inflammatory bowel disease and chronic inflammation. Confounders are acute infections and the use of NSAIDs. So the lower cutoff is there. Have to say that this is not a good screening test for microscopic colitis. Most of the patients with microscopic colitis will still have normal calprotectin. But it helps you distinguish IBS from IBD, as we heard before. And we'll do ileocolonoscopy when there's alarm signs or symptoms, when there's elevated calprotectin. And above the age of 50 here is still the guideline in Belgium, but as you heard from Tim, in those who are symptomatic, we tend to lower now this threshold going to 45 years. And if you do the endoscopy, the ileocolonoscopy, take left-sided and right-sided colonic biopsies for collagenous or microscopic colitis. There's a guideline, a European guideline, to manage patients with bowel disorders with diarrhea. I contributed to the guideline. I'm like half happy with it, but I will show you some statements because I think it has some useful findings. My problem is that they lump together for this guideline IBS-D with chronic diarrhea, and I think there are too many differences there to justify this in a systematic approach. And I personally would have liked to see an IBS guideline with focus on IBS-D as well, and then a chronic diarrhea guideline because they are different. On the left, you see the diagnostic criteria for IBS-D. We've had these. On the right, the criteria for functional diarrhea. Loose or watery stools without predominant abdominal pain or bothersome bloating, that is to distinguish it from IBS and bloating, occurring in more than 25% of the stool. But the typical chronic diarrhea patients will have almost always diarrhea. Criteria present in the last 6 months and active in the last 3 months. And patients with IBS-D, so pain related to the bowel movements, should be excluded. Very simple definition. For the European consensus, there were many statements. The participants could score between A+, agree strongly, to D+, disagree strongly, and more than 80% A or A+, agreement, minor reservation, or agree strongly, were viewed as consensus if this was more than 80%. And so We start the consensus by saying IBSD and functional diarrhea are two potentially overlapping disorders, 96% agreement. I was less in favor of that. I would like to see them split, but this did not happen. And in here, the consensus says in all patients with chronic diarrhea, ask about fecal incontinence, because this is sometimes part of the driver to consult. It's very distressing, and many patients will actually feel inhibited to communicate that. So whenever is diarrhea, I ask for urgency. Do you need to rush to the toilet? And those who say, yes, I sometimes have to rush, I ask, have you had accidents? Has it happened that you come too late? And many of the patients will say, yes, it happens once or twice. And then I tell them this is not rare, you know. Many people have them. I reassure them that is not exceptional. But of course, people don't talk about that to each other. This is really what I say. Then the consensus says a symptom-based approach with limited blood testing, blood count, CRP, serology for celiac disease, celiac-associated antibodies should be tested. Against routine testing for enteric pathogens, we mean parasites, mainly there, except in those who have traveled exotically, do calprotectin and colonoscopy in patients older than 50 years, according to the local cancer screening guideline, and always do the biopsy. So that is in line with what I told you before. They recommend against the use of breath test in patients with suspected functional diarrhea to identify carbohydrate malabsorption. Remember I told you about lactose intolerance? There are other intolerances for carbohydrates, but actually it is said that the breath tests lack specificity and sensitivity, and you better work with an empiric elimination diet. And then tests that they say are obsolete are these. IgG food allergy testing, not useful, gives false positives. It shows the patient so-called reaction to a food agent. If they eliminate it, doesn't make a difference. These are costly tests in our patients, very frequently used. I always tell them it's a waste of time. Some patients who do the test eliminate what is in red. They do the test 3 months later. They have different IgG that now have emerged. So this is a non-specific phenomenon, and certainly not useful is this detailed stool microbiota analysis, where if it's in the red, too little, or in the red, too high of some bacteria, then the patients think this is driving their symptoms, including diarrhea. Then they ask me what to do with that, and then I ask them, the one who ordered the test, because I never ordered these tests, what was his or her suggestion? And then they say, well, they didn't know. Then I tell them it tells everything. They do a test that they don't know how to apply. Costly, not useful. We do stool microbiota analysis in our research in most of our studies, not in clinical practice. It's not ready for that. Then they recommend for testing for bile acid diarrhea with CHǳ testing or other biomarkers. There's a blood test, C4. You can also measure in the blood FGF, an FGF factor, but these are not routinely present. And I will very often use empirical therapy. I will tell you something later about it. So in the patient's chronic diarrhea, this is the algorithm from the UEG and the ESNM. Symptom-based approach, assess the presence of fecal incontinence and alarm features. If they are present, do investigations. If not, limited screening tests, full blood count, CRP, celiac serology, and fecal calprotectin. The thyroid function is not here. I often do it, but it's not cost-effective shown. If any abnormality, work on it. If not, look at whether there's predominant pain. This is IBSD. This is what LUKAS told about. If there's not prominent pain, this is functional diarrhea, and then you can go to treatment. If treatment doesn't work, you can go for further testing, colonoscopy with biopsies to eliminate or exclude microscopic collagenous colitis and some other tests. And actually the test for bile acid malabsorption, they put here at the end. After capsule endoscopy, so I think after colonoscopy with biopsies, I think that doesn't do justice to the problem of bile acid malabsorption, which may be there in 20 to 30% of the patients with chronic diarrhea, with or without pain. In terms of treatment, so very early on, the guideline says empirical therapy, not an antispasmodic. They do not work for functional diarrhea, probably, but loperamide. And loperamide is underused. I see a lot of patients with chronic diarrhea who never used loperamide. So this is a good one to use. And loperamide, well tolerated, does not cross the blood-brain barrier, slows transit in the small bowel and the colon, inhibits secretion, increases anal sphincter pressure, so helps the continence. The problem is a huge variation in required and tolerated dose. So I start with 2 or 4 milligrams daily, go up. You can actually go to 6, 7, even 12 pills a day in extreme cases. Titrate this up. If 2 milligram causes constipation, this is likely to be a functional low volume stool diarrhea. I can go lower with pediatric formulations to 1 milligram of 0.5. There's about 3 or 4 genetic polymorphisms involved in the activities through which loperamide can slow transit and inhibit secretion. That is how you get such a large dose variation. And it is effective for chronic diarrhea. People don't often like it because it does inhibit transit, not by relaxing the bowel, but by imposing a stationary non-propulsive contraction. And that gives some discomfort in some patients. That is why in the IBS trials, you've seen this before from LUKAS, it doesn't improve pain, only diarrhea and urgency. But it's a good first choice, very cheap old drug. And then very often a early next step that I do, I put 1 or 2 things in between that I will tell you later, is to just try a bile acid sequestrant. So they recommend for the use of a bile acid sequestrant, if testing is not available, a trial of bile acid sequestrant should be considered. If you have the test, do it, but do it early on. Actually, after you've done the initial workup with blood works, and maybe if you tried loperamide and maybe ondansetron, which I will mention later on. If you have the test, do the test early on. If you don't have, I actually will use a bile acid sequestrant very early on after loperamide, and then I have the patient choose between a bile acid sequestrant and ondansetron. So what happens if bile acids are not absorbed at the terminal ileum and recirculated to the liver? You have 2 things. The liver needs to make more bile acids just to maintain the production and the ability to absorb fat and digest fat. And the signal to the liver is C4. And you can test it in a blood test. And so if bile acids do come into the colon, they do 2 things. They stimulate contractions. The very first study I did as a research student in internal medicine was to perfuse bile acids in the colon of patients with IBS, and they got severe cramps. And the second thing it does, it produces water secretion in the right-sided colon, which can be voluminous. And you can test it with a CHǳ test by measuring C4 or FGF19 in the blood, or by quantifying bile acid content in a 24-hour stool collection, but this is very laborious. And you can actually just give a bile acid sequestrant, for instance, cholestyramine or colsevelam, if you have access to it. This is an unselected group of IBS patients, IBS SSS score, put on cholestyramine, and you see a progressive increase with a response in close to 50% after 8 weeks. Colsevelam, compared to placebo, decreases stool frequency and improves stool consistency. If patients have had a cholecystectomy, you almost know that this is going to be bile acid diarrhea, and you can early on start this as an open label treatment. You see here the response pre-colsevelam, post-colsevelam, and you see the cholecystectomy patients here in the dotted line. If you don't have the test, try this empirically. If you have the test, do the test. It allows you to go over some intolerances. With cholestyramine especially, can give upper GI upset. Then the low FODMAP diet works in IBS with diarrhea, but it probably also works for some types of diarrhea, so you can use it as well there when bloating, no pain, but diarrhea is present. And then the guideline also recommends for the use of 5-HT3 antagonists. Abroad, they have velocitron, ramositron. This is the US, this is Japan. We have ondansetron, not approved for diarrhea or IBS, used for chemotherapy-induced nausea and vomiting, but this works. This is the overall studies with ramosetron, with allosetron, and at some point studied but never made it to market cilancetron. And this is a study that was done in the UK with ondansetron, looking at the Bristol Stool Form Scale. People starting 4 weeks placebo, then crossing over to ondansetron, you see the improvement in Bristol Stool Scale. They go from around 5 to around 3.5. And this is the placebo, this is the active first ondansetron. There is a decrease in Bristol Stool Scale consistency. And then when they cross over to placebo, this effect is gone. It does not affect pain, but it is ideal for diarrhea. Now, in this study, patients took on average 5.6 grams. I have to tell you, I start with 4 milligrams, and very often I need to go down to 1 or 2 milligrams or even 0.5 milligrams made by the pharmacy, because this is causing a lot of constipation. It is well tolerated, titrated doses made by the pharmacist. 1 milligram is a good starting dose. So this is a treatment summary. Low FODMAP was recommended for diarrhea, eluxadoline more for IBS. Loperamide was recommended, rifaximin more for IBS. And then there were some arguments in favor of bile acid sequestrants and 5-HT3 antagonist. Against, don't use a gluten-free diet, don't use mesalazine in a non-inflammatory diarrhea, don't use FMT, and don't use SSRIs. Any other approaches that I use? Yes, I do. So I will very early on use low dose of Ispagula. This has a decreasing and binding effect on the number of stools and their consistency compared to baseline, similar to loperamide. It's very well tolerated. Low doses, don't go high, you may worsen diarrhea, but low doses, half a sachet, for instance, of Ispagula, binds the stool, improves consistency. This is another study, control of urgency, 25 patients with chronic diarrhea in a crossover. Loperamide was actually inferior to Ispagula. So use this early on in the non-large volume stool, especially in those with urgency. It will help. And then locally acting agents, there is gelsectan, which is a mixture of xyloglycan, pea protein, and grapeseed. And in the UK, they have Enteros gel, a similar absorbent effect. This has an absorbent effect. And these are studies looking in IBS on quality of life, it's improved, but especially looking at normalization of the stools. And you see here, those who started on active in blue, clear-cut normalization, lost when crossover to placebo, and the opposite in the placebo going to active agent. This is luminally acting, it's a food supplement, it is safe. Second line testing, blood tests, inflammation. We've shown these. If there's no benefit, then you can actually do measurement of stool fat, 27-hour collection, or the spot test, the Congo red, the staining as I showed you. Consider testing for SIBO in those who have been on a PPI for a long time, the CHǳ test. Gut hormones you can look at, but this is rare. And I don't do the osmotic gap in stools because this is not specific enough. So let's show you a case. 73 years old woman who comes to us. She's had diarrhea and abdominal pain for 20 years. It has exacerbated the last year. She now has 2 to 5 loose stools a day, and she lost 8 kilos. She had a colonoscopy with biopsies, which was actually negative. Before that, I would have said this has to be microscopic colitis, because she is old, she has weight loss, and especially if they have been put on a cardiovascular drug recently and nocturnal bowel movements, this increases the yield of looking for microscopic colitis. However, this was negative. She had a gastroscopy with duodenal biopsies, also negative. No Giardia, no celiac, unlikely at this age. And the lab was also negative. Tentative diagnosis IBSD, but the 8 kilos of weight loss are really disturbing there. Empirical therapies with loperamide, spasmolytics didn't help, probiotics didn't help, cholestyramine was justifiably tried and didn't work. Ondansetron was not tried yet, but then because of the weight loss, a stool collection was done. And surprisingly, this is not entirely clear from the history. This is a massive large stool volume. 1 kilo of stool a day with only 9% dry matter. This should normally be 15%. With a rapid transit, 45% of the label was already in the stool on day one, and normally this should be less than 5%. So we have a mixed effect here. A watery diarrhea, a very rapid transit diarrhea. There was 30 grams of fat, so there is a steatorrhea component as well. And this was not a bile acid malabsorption. There was only 0.44 millimoles bile acids per day, whereas normally this should be this can go up to 1.1. So very large volume, very low percentage dry matter, steatorrhea, and a rapid passage of the label into the stool. And so further blood screening showed actually abnormalities in the electrophoresis with a abnormal band, and a deep rectal biopsy actually showed positive for amyloid. So this is a patient with amyloid. We don't have a very good causal treatment for that, and that then needs to be transferred to hematology, who will look further for that. The other thing to consider in this type of story, large volume, steatorrhea, weight loss, is looking for pancreatic insufficiency. The screening test is fecal elastase testing in the stool. If this is below 200 micrograms per gram, it's a sign suggestive of pancreatic exogenic insufficiency, exocrine insufficiency. We have a breath test which measures triglyceride digestion. The confirmation is a 24-hour, but rather a 72-hour stool collection, where you look at steatorrhea if you have more than 7 grams fat per day in patients who continue to eat fat, of course. Alternative, the Sudan stain on the spot stool, as I showed you before, and an acid steatocrit, which I think is less reliable, less sensitive in our hands. So the breath test, I will not go in detail. And after Roux-en-Y gastric bypass, many of the patients also will have some fraction of steatorrhea. Up to 90% will have steatorrhea and diarrhea. Treatment, pancreatic enzyme replacement therapy. Of course, image the pancreas if there's no surgical history or no bacterial overgrowth in the small bowel. And then you use exocrine. Pancreatic supplementation. Creon is the brand name that we use. This is exogenous lipase. In chronic diarrhea, without a good explanation, you can use somatostatin analog. Octreotide, 3 times daily subcutaneously or 1 times monthly, the long-acting repeatable form, will dramatically decrease the stool volume and the daily stool frequency. This is an old study by Michael Farthing, done in the 90s already. And we have done one study, open label, patients with large volume stool, 33 patients, more than 200 grams a day, were treated with another somatostatin analog, lanreotide, 120 milligrams, twice with 1 month interval. And we looked at reduction of stool frequency, or reaching less than 3 stools per day on day 28. And you see that there is a response group of around 40% of the patients who reached less than 3 stools per day on day 28, and sustained to a large extent with a small growth on day 56. That was not a primary outcome variable. And the number of stools went down from around 5.7 to 3.7 per day. In the responder group, this went to less than 3, 2.3 per day. So this is something you can use. Side effect, it worsens steatorrhea. So do this for large stool, watery diarrhea, not steatorrhea, because that will be worsened. So I told you this one, I added the hygroscopic fiber. This is a good one to add. Second line approaches, you've heard. You can use the local acting agents like Gelsectan, which I showed you. And in the UK, you have enteros gel. And in the difficult patient, think about pancreatic enzymes and somatostatin analogs. Thank you for your attention, and I'll be happy to entertain any questions. Ik hoor niets van vragen. Nee, nog altijd niet.
Hello? Does anybody
Yes,
hear me?
now I hear you. Yeah,
Okay, sorry.
we're ready for questions.
Okay, thank you very much for this nice overview. Very clear, very nice workup as well for the diagnostics as the treatments. I would like to encourage everybody to put their questions in the chat. I don't have any questions right now, but to start off, interesting the cutoff between small volume diarrhea and large volume diarrhea. Where do you put the cutoff to go for more extensive testing? Because I can imagine that lots of people have like 300 grams a day. Is that already considered an important cutoff? Do you go on for, is that an alarm feature or not yet?
Well, it's not an alarm feature, but anything above 200 grams a day, I do advanced testing. Because 200 grams is the cutoff, but many of the patients with a small stool volume, if you would collect it, they will have 100, 120, 150 grams a day. So 200, I think, is really a robust cutoff. If it's above 200, I think something is wrong with the absorptive or secretory functions of the bowel. And then I really want to know what is in there. And we anticipate this to some extent because we never only measure the volume. If I order this, it's a 3-day stool collection, and I immediately ask for water content. I ask for quantification of fat and bile acids in the 72-hour stool collection, and I put in a transit marker as well. So I actually already anticipate that. But if you go into 2 steps, if you would measure the stool volume, 200 in the Western world, definitely. In Africa, it would be 300, have to add, but 200 is definitely abnormal. Then you look for additional testing. Steatorrhea, you can test for hormones, whether there's any neuroendocrine tumor, but these are very rare. That's why I hardly address these.
Okay. There is now a question in the chat, how to decrease frequent urge for defecation. So I guess the question is more about, can we only address the stool frequency or should we add something else for the urge and the urge incontinence?
No, I do, and I think there are several ways where you can cut down on urgency. Loperamide is one. It increases the strength of the lower sphincter, the anal sphincter. That may give a little bit of comfort, but it does not inhibit the contractions that drive the urgency. So for that aspect, there's 2 things which are better. The soluble fiber supplement, low volume, may actually help for urgency, and ondansetron. Ondansetron really helps for urgency because that works by relaxing the bowel, including the rectum. It increases the rectal volume for the same intrarectal pressure. So that is a very good one for urgency. Beside that, of course, if you know the cause of the diarrhea, let's say it's somebody taking a lot of sorbitol or it's somebody with some lactase deficiency, well, then eliminating that will also help the urgency.
Okay, thank you. You very shortly alluded on IgG testing and that it's not useful to come up with causes of diarrhea. What about IgEs?
IgEs you can test for, but these people will not present with diarrhea. So a true food allergy actually presents with very acute pain, cramps, some diarrhea, but usually with extra intestinal manifestation. These people may have a skin rash or may develop some wheezing, for instance, or a swelling in the throat. And in these, you can probably take a look at IgEs to find out what are the candidate mediators. However, atopic constitution is very, very prevalent in the population. Many of these have IgEs against food that you can detect with testing, who are also not relevant for their pathology. So food allergy, IgE mediated, has a very particular presentation with allergic manifestations outside the GI tract. In the others, neither the IgE and especially not the IgGs you should look for.
Okay, thank you very much. I think we had a really nice and extensive overview already, and if there are no further questions, in the interest of time, I would go to the last presentation of the day and also of these 2 days,
Yeah.
which will be discussed by Professor VANUYTSEL, and it will be, like Professor TACK already alluded to, an umbrella presentation on the use of neuromodulators in GBIs. Professor VANUYTSEL, the floor is yours. As I said, the screen is yours.
Thank you very much, Carlien, for the introduction. So the final presentation of the masterclass, I hope you enjoyed it so far, will be a bit of a different topic. So we have guided you through the conditions of esophageal dysmotility, of gastroduodenal disorder, small bowel and colon. Now I will try and present you a more overarching topic on the use of neuromodulators in all of these conditions combined. Because this really is a topic where we as gastroenterologists usually feel a bit less comfortable with, but this should be part of your toolbox. You should not be afraid to use antidepressants, which we now call neuromodulators, in your patients. Why do we do that? Well, this overview has been introduced to you by Dr. Balsiger, and he discussed the biopsychosocial model that we use now to understand the pathophysiology of disorders of gut-brain interaction. This means that we should not ignore the fact that our patients have a higher prevalence of psychosocial problems, including increased levels of life stress, anxiety, depression, sometimes lack of coping skills, sometimes lack of social support. But it's not a psychosomatic condition. We know very well that there are also alterations in the physiology in the periphery, which is in the GI tract itself. And this was discussed during several lectures over the last 2 days, including changes in motility, changes in sensitivity, activation of immune cells with a prominent role of mast cells and eosinophils, and changes in the bacterial flora as well. And it's really the interaction between the central psychosocial factors and the peripheral gastrointestinal factors which are extremely relevant to understand the disorders of gut-brain interaction. And this is why in Rome 4, the main title was still functional gastrointestinal disorders, but as you can see, the subtitle has become the disorders of gut-brain interaction. And this will be much more important even in the next iteration of the Rome criteria, which are expected in 2026. So there is an interaction between the gut and the brain, and this is one of the reasons why neuromodulators, antidepressants can be useful. And the communication between the brain and the gut follows 2 pathways. First, it will the communication takes place through the autonomous nervous system, mainly the sympathetic nervous system and the vagus nerve, where the nociceptive signals are relayed by the sympathetic neurons, where the more physiological stimuli will be transmitted by the vagus nerve and the pelvic nerves. And on the other hand, we have the HPA axis, so the hypothalamus pituitary adrenal axis, which is an endocrine system, ultimately resulting in the release of cortisol and noradrenaline by the adrenal glands. The relationship between central problems, anxiety, depression, and the gastrointestinal manifestations of the gut has always caused a lot of controversy. And this is the reason that some of our colleagues will call these conditions psychosomatic, because they think that the origin of these diseases, it really lies in the brain or psychological. However, when you do a longitudinal study looking at what comes first, the results are actually quite surprising. So this is a cohort study where patients were followed over the course of 10 years, and it was clear that in 1/3 of the individuals, indeed, the anxiety, the depression, the stress preceded the development of a disorder of gut-brain interaction, like IBS or functional dyspepsia. But in 2/3 of individuals where both of these problems were combinedly present at the same time, so both a GI problem and a central problem, the gastrointestinal issues preceded the development of a neuropsychological problem like anxiety. So in most patients, it is the GI tract that comes first. And this is also the reason that we call this the disorders of gut to brain interaction and not vice versa. So why do we want to start neuromodulator therapy? Well, exactly because of this interaction between the gut and the brain. There is psychiatric comorbidity, including anxiety, depression, stress, and so on. Also, these neuromodulators, also when they're used in depression, they have non-specific effects as well. They will make you sleep better. They will improve your general well-being. And this is also to the advantage of our TGBI patients. But the reason that we specifically use them in IBS and functional dyspepsia, for example, is that they have effects on pain-related circuits of the brain. This also makes them useful in other conditions of chronic pain, like chronic back pain or headache. And I will come back to this in a minute. And they will do so by having the effect on the brain regions processing pain itself, but also on the processing and the transmission of pain from the periphery, from the GI tract to the brain stem by descending projections. And I will explain you in more detail. From animal data, we also know that neuromodulators have an effect on neuroplasticity as well, where at first it was thought that neurons are not replenished. We now know that there is regrowth of neurons and that there is plasticity of neurons in these pain modulating areas, like the anterior cingulate cortex, when these animals were treated with neuromodulators, including tricyclic antidepressants. And finally, and specifically relevant for the GI tract, we know that neuromodulators also affect the GI tract itself. Tricyclic antidepressants, for example, they have anticholinergic effects, and thereby they will slow down colonic transit. And this makes them very useful, for example, in patients with predominantly diarrhea. In contrast to SSRIs, selective serotonin reuptake inhibitors, by the increased availability of serotonin in the synaptic cleft, they will accelerate transit. So looking a bit more in detail at this brain-gut interaction, this is a normal homeostatic system of gut-brain interaction in a healthy individual. And as you see here depicted, normal physiological stimuli will not be perceived consciously. They will be blocked by a so-called sensory filtering and will not be perceived by the individual itself. And this sensory filtering, the neuroanatomical substrate of this, are pain modulatory pathways, which are descending from the brainstem to the spinal cord. And these use neurotransmitters, for example, like noradrenaline and also opioids. Of course, salient and noxious stimuli, they will be perceived consciously. This should be the case because, of course, danger and potential danger signals should activate your brain and, for example, cause a fight or flight reaction. And all of the interpretation of these incoming signals will be affected by a cognitive circuit. What does this mean to my individual well-being? Affective as well. What type of emotions does this evoke? And also a reward system, for example, related to food intake. In patients with an impaired interaction between the gut and the brain, we know that this sensory filtering is impaired. And this is because there is a problem with these descending neuromodulatory pathways from the brainstem, allowing also innoxious stimuli, physiological stimuli, to penetrate into the brain and to be perceived consciously by the individual. This will be perceived as pain, potentially dangerous, and of course these signals will then be interpreted by an impaired cognitive circuit, modulated by overactive affective circuit, and this can lead, for example, to somatization, where other bodily symptoms are perceived as well, or catastrophizing, where patients are exaggerating the potential impact of these sensations that they feel. So what can we use to try and modulate this defective response? These are the neuromodulators, and the most commonly used ones are the antidepressants. But as discussed, the terminology that should be used nowadays to avoid the stigma that is associated with the terminology of antidepressants is really neuromodulators. And this is also how we explain this to patients. Antidepressants most commonly work by blocking a presynaptic reuptake pump. So this is the presynaptic neuron. The antidepressant here in red will block the reuptake pump, and this will increase the concentration of the neurotransmitter, these yellow triangles, in the synaptic cleft, hence activating more extensively the postsynaptic neuron. And depending on the type of neuromodulator, you will have an increase of serotonin, noradrenaline, and so on. And I will explain you this in more detail. So the terminology to be used is neuromodulators. Not all neuromodulators are the same. I would really like to advise you to read the paper that you see on the right. This is a paper from the Rome Foundation with Professor Drossman as the first author, published in 2018. And this contains all the necessary information that you need on neuromodulator treatment in disorders of gut-brain interaction. The type of molecule, the effects, the potential side effects, doses, and so on. So I will guide you through this in an abbreviated manner, of course. And first class is the SSRIs, or the selective serotonin reuptake inhibitors. Very specific drugs. They will block the serotonin reuptake pump in the presynaptic neuron. Examples include citalopram or escitalopram. And the indications of SSRIs are patients in whom you want to improve general well-being, anxiety, or depression, but not so much pain. So this is more a treatment for general symptoms rather than specifically addressing pain. Tricyclic antidepressants, where amitriptyline and nortriptyline are the most commonly used, are dirty drugs. And what I mean with this is that they will have an effect on multiple receptors, going from histamine to muscarine receptors, serotonin and noradrenaline reuptake inhibitors. And very specifically, these TCAs are effective in reducing pain. And the reason that they do this is because they block the reuptake of noradrenaline in the presynaptic neuron. And by increasing the concentration of noradrenaline, you will enhance this descending neuromodulatory pathways, thereby reducing pain. I tend to use a lot of nortriptyline, and the reason is that nortriptyline is a pure noradrenergic reuptake inhibitor, so a pure NRI, which does not have, at least to a lesser extent, the effect on all of these other receptors. Amitriptyline and other tricyclic antidepressants also have an antagonistic effect on the histamine receptor 1, which can contribute to decreased pain and reduction of nausea, but also contributes to the adverse effect of sedation. Anticholinergic side effects will slow down transit, including leading to constipation. Anti-alpha adrenergic effects can lower the blood pressure, and the antagonistic effect to serotonin 2C receptor has an effect on appetite. It will stimulate appetite, thereby leading to increased weight. Tetracyclic antidepressants or serotonergic antidepressants, the most commonly known molecule here is mirtazapine, and these drugs are very effective in improving appetite, reducing nausea, and this is because they block the serotonin 3 receptor, leading to reduction in nausea. This is the same effect that, for example, ondansetron has, thereby reducing nausea. They also have an antagonistic effect on the serotonin 2C receptor, improving appetite. They have antihistaminergic and anti-alpha adrenergic effects as well. So mirtazapine can be used in patients who have lost considerable weight, because it will increase appetite, thereby improving the weight, and it will also regulate and improve sleep quality. And finally, we have the SNRIs, the serotonin and noradrenaline reuptake inhibitors. There are two big representatives of this class. This is venlafaxine, but venlafaxine is not a great drug to be used in patients with GI disorders. And the reason is that you want to achieve the NRI effect, the effect on noradrenaline. But in order for venlafaxine to achieve this effect, you need very high doses, more than 225 milligrams of venlafaxine. And this is not what you would commonly use in daily clinical practice. And in this case, if you want to go that high, it will cause some nausea, which is the limiting adverse effect for all SNRIs. Duloxetine can be used at lower doses, already at 30 milligrams, 60, sometimes higher. And this also comes with side effects like nausea, but because the NRI effect will already appear at lower doses, this is a very useful drug as well. So this is a summary of the different neuromodulators that can be used. So make sure that you understand this and you know which neuromodulator to use in which case. So now let's go over the spectrum of gastrointestinal conditions, specifically disorders of gut-brain interaction, and give you some hints and some evidence which neuromodulator can be used in which situation. So for reflux symptoms, the neuromodulators are specifically useful for patients with reflux hypersensitivity, meaning normal acid exposure time, but a positive association between reflux and the symptom, the positive SAP, as you may remember from the presentation of yesterday, and in patients with functional heartburn. Again, normal acid exposure, but in this case, there is no correlation whatsoever between the appearance of a reflux event and the appearance of symptoms. And the more you go from patients with erosions and non-erosive reflux disease, but an abnormal acid exposure time, towards the conditions with a normal acid exposure time, the more likely that esophageal and central hypersensitivity will come into play. So this is the conditions where you want to use a neuromodulator and where the target is esophageal hypersensitivity. The third condition is the non-cardiac chest pain. Patients experiencing chest pain in whom a myocardial infarction has been excluded as the underlying cause. So basically chest pain refractory to PPI. So first, let's start with NCCP, non-cardiac chest pain, where the evidence is there for tricyclic antidepressants. Many of these studies are quite old, and you will see this in the appearance of the figures as well, but still they're relevant to know. This is an old study, 60 patients with refractory chest pain and exclusion of a cardiac origin of this chest pain, and they were randomized between 3 groups: placebo, clonidine, which is a co-analgesic drug, alpha-2 antagonist, which is often used in patients with chronic pain, and imipramine, which is an older tricyclic antidepressant. Looking at the effect on chest pain, lower is better. You see that with the imipramine, which are the squares, there is a significant drop in the frequency of pain after the treatment of 4 weeks in this case, but not with clonidine or with placebo. But of course, the criticism of this type of studies is always that maybe you are just improving the psychiatric state and this is explaining the improvement in chest pain as well. Well, this was not the case. Improvement of psychological symptoms with imipramine and the squares was similar to the improvement with placebo in triangles. And splitting the group into patients who had a normal psychiatric workup, always on the right, and those with an abnormal psychiatric workup, you see that in the imipramine group, the responses in terms of the frequency of chest pain was similar. So the response in terms of chest pain was not mediated through the presence of psychiatric symptoms at all, nor was this the case in the clonidine group. The only group in whom this made a difference was the placebo group, where patients with abnormal psychiatric comorbidity, anxiety, depressions, those were the ones who were more likely to respond to placebo, which is quite interesting, I think. Second study, another TCA study, patients with chest pain not responding to a PPI treatment for 1 month. They had a normal workup, they had a normal gastroscopy, they also had pH impedance, esophageal manometry, and cardiac comorbidity was excluded. This is an open label study, but in this study you see that by adding amitriptyline to rabeprazole, there was a significant benefit over giving a double dose of rabeprazole, but without amitriptyline by week 8. But an open label study, so to be taken with a grain of salt. An interesting study is a study with a tetracyclic antidepressant, trazodone, very old molecule, now mainly used as a sleeping aid for patients who have problems sleeping through the night. Low numbers of patients, published in Gastroenterology in 1987, so quite an old study. These were patients who had all kinds of esophageal symptoms, including chest pain, but also had an abnormal manometry. Patients were then randomized to placebo versus trazodone, and the trazodone was started at 50 milligrams once daily and was then increased to a frequency of 3 times daily, which is quite high and not very commonly used in clinical practice because this was given morning, midday, and evening, and so this comes with some drowsiness. But with the trazodone in this study, indeed, both the frequency of chest pain, black curve is trazodone, and the intensity was indeed better than in the placebo group. And in this group as well, those who responded to the trazodone had a superior improvement of anxiety, depression, somatization as well, but this was not driving their symptoms. Also, there was no effect on trazodone on the esophageal manometry, which was abnormal. So it's not by improving the manometry that the symptoms were improving in this case. So this was a story for non-cardiac chest pain. Tricyclics are effective. This is a very different story in patients with refractory heartburn. So patients who feel heartburn where this is not caused by reflux per se. So these are 83 patients with heartburn symptoms not responding to PPI treatment, randomized to imipramine versus placebo, and both in the intention to treat as in the per protocol group, no effect over placebo. Remember, patients not responding to PPI, this can entail many different subgroups, and indeed in this subgroup you had both patients with esophageal hypersensitivity, positive symptom association, and patients with functional heartburn, negative symptom association. But in neither of these subgroups, you could see a benefit of imipramine versus placebo. So the efficacy of TCAs in refractory heartburn, according to this study, was limited. In contrast, SSRIs, where in general I told you that this is not very useful for pain, there is some evidence for esophageal type of pain or chest pain. For example, patients with non-cardiac chest pain, sertraline versus placebo, 8 weeks. Again, already by week 5, 6, 7, there is an improvement of sertraline versus placebo in terms of reducing the severity of chest pain. And also in patients with refractory heartburn, in contrast to a tricyclic antidepressant, fluoxetine, in comparison to placebo, and in comparison also to the PPI, but of course they were refractory to PPI, but only fluoxetine, the SSRI, reduced the frequency of refractory heartburn, here depicted as the percentage of heartburn-free days, 80% with fluoxetine versus 30% with placebo. So this is a lot of information, but in summary, patients with non-cardiac chest pain, you can use either an SSRI or a tricyclic antidepressant, and this is challenging a bit the paradigm that SSRIs should not be used for pain, but in the esophagus is different. However, in patients with refractory heartburn, there is more evidence for an SSRI in comparison to a TCA. Very difficult topic, and this was discussed yesterday by Carlien, so I will not go too much into detail, is the esophageal hypomotility. You saw this list yesterday, and when there are lots of options, none of them work very well, but at the bottom of the list, you see buspirone. Buspirone is serotonin 1A agonist, which can be used to improve motility. So the way that we address ineffective esophageal motility is first to treat reflux if it is present, and then use, for example, pyridostigmine, prucalopride, and finally buspirone. This is an old anxiolytic drug, but it has been shown here in healthy volunteers that buspirone will increase the amplitude of the wave. The shaded area is buspirone, the white area is placebo, and also the duration of the wave, 10, 30, and 60 minutes after administration. This is a study that was shown yesterday, patients with systemic sclerosis. There was an increase in the pressure of the lower esophageal sphincter. However, a more recent study evaluated the effects as a small study, evaluated the effect of buspirone in a crossover design. There were 8 patients who were treated with placebo and with buspirone only for 2 weeks. And in this study, there was no impact on severity and frequency of dysphagia. But of course, small study, small numbers, and short durations of treatment. We are now performing a longer-term study, also better characterized by manometry and symptoms. So, chest pain, go for tricyclic antidepressants or an SSRI. Functional heartburn, go for an SSRI. Esophageal hypomotility, potentially buspirone. So now let's move to functional dyspepsia. Gastroparesis was discussed yesterday. You start with H. pylori, test and treat, PPI, and then prokinetics. But in many patients, you will need to start a neuromodulator. This is a study from our own group by Lucas van Oudenhoven, where in healthy individuals, there is a dose-dependent increase in the post in the volume of the proximal stomach. So this induces actually a gastric relaxation, very similar to gastric accommodation. And you can see here the increases in volume, which improves with the dose of buspirone. This is a study also from our group a couple of years ago already. Patients with functional dyspepsia, proof of principle study, 10 milligrams 3 times daily versus placebo. And looking at severity of dyspepsia scores, there was a significant drop if you compare the after 4 weeks of treatment with buspirone compared to the pre-treatment severity of dyspepsia. And looking at individual symptoms, mainly the postprandial symptoms improved, which makes sense because buspirone will act in improving gastric accommodation. So there was less fullness, less bloating, and less early satiation. So this is a drug which can be used for mainly patients with postprandial distress syndrome, but beware, it can cause some somnolence and some dizziness. Large study from the US, almost 300 patients with functional dyspepsia. Professor TACK showed you this yesterday. Patients were randomized between placebo, tricyclic antidepressant amitriptyline, and an SSRI, escitalopram. And looking at adequate relief, only the tricyclic antidepressant, but not the SSRI, was effective in providing adequate relief compared to placebo. Looking into the subgroups, only patients with epigastric pain and not those with the postprandial symptoms were better off with amitriptyline. So this is a drug for pain, which confirms again tricyclic antidepressants are effective in pain. Similar, slightly different story in gastroparesis, so delayed gastric emptying and mainly symptoms of nausea, vomiting with some fullness and early satiety. Nortriptyline, so pure NRI, in this study was not effective in reduction of nausea, fullness, and satiety, even if you see a trend. So there may be a power and sample size issue in this case. And finally, for functional dyspepsia and postprandial symptoms, this is a study from Professor TACK. 34 patients with functional dyspepsia who had lost a significant proportion of their body weight prior to study inclusion, but without psychiatric comorbidity. And they were randomized between 50 milligrams of mirtazapine versus placebo. You remember that these tetracyclic or serotonergic antidepressants, that they are effective by antagonizing serotonin 3 receptor, reducing nausea, and also, and importantly, by blocking the serotonin 2C receptors, thereby improving appetite. In the study, already by week 4, there was a decrease in the severity of dyspeptic symptoms, and this was important and to our advantage in this study, there was an increase also in body weight. And this in some patients can go up to 10 kilograms of weight, which is an adverse effect in some populations, but in patients with dyspepsia, postprandial symptoms, and loss of body weight, this can be a desired effect. Pregabalin is an alpha-2 delta ligand agent, which will act on the presynaptic neuron, downregulating the triggering of the presynaptic neuron. Looking again at pain, already by week 2, but reaching statistical significance by week 4, and this was sustained until week 8. 70 milligrams of pregabalin reduced the rate of response in terms of reduction in abdominal pain. There was no effect on postprandial symptoms. This purely works on pain, similarly to the tricyclic antidepressants. This study was shown yesterday as well. Venlafaxine is an SNRI, but you need very high doses in order to achieve the increase in noradrenaline, and thereby this study was negative. Moreover, with venlafaxine, lots of dropouts because of side effects, including nausea. So also in this case, venlafaxine should not be used. If you want to use it, if you want to use an SNRI for pain, the drug to go to would be duloxetine. And then a small study from Lebanon that I wanted to show you as well is an anxiolytic, a fixed combination of flupentixol and militracin, which is used for anxiety mainly. But in this study, crossover study, you see that with this combination anxiolytic, there is a drop in the Nepean dyspepsia index, which will go up again at the end of the washout. So a drug that we don't use very often in clinical practice, but especially if there is comorbid anxiety, this can be considered for your difficult functional dyspepsia patients as well. So in summary, for postprandial symptoms, the tetracyclic mirtazapine can be used, and maybe buspirone. I didn't mention sulpiride, an older antipsychotic drug, which also has anti-dopaminergic effects, thereby reducing nausea and improving appetite as well. This is also useful, but you should go for the low doses, not the 200 milligrams, but a 50 milligrams, which is usually a quarter of a tablet of sulpiride. For pain, epigastric pain syndrome, pregabalin can be used, alpha-2 delta ligand agent, or a tricyclic antidepressant. Then finally, let's move to irritable bowel syndrome, IBS. I do not have to explain you the definition, but pain is a predominant symptom, and therefore neuromodulators can be useful here as well. It should be differentiated from centrally mediated abdominal pain, and the difference really is that in IBS, as Lucas explained you, there is a clear connection between peripheral events like opening of your bowels, having diarrhea and constipation, and the pain. So it is the bowel movements that are triggering the pain. This is not the case for patients with centrally mediated abdominal pain, where both are existing independent of each other. The pain in these patients is continuously present. It's present day and night. They wake up with pain, they go to bed with pain, and this has an effect on their daily functioning as well. In these patients, there is no need to try and start a spasmolytic drug because the pain is not triggered by the GI tract. You should not use a diet. In these patients, you should have a low threshold to include a psychologist in your multidisciplinary team as discussed, and also to start neuromodulator treatment early on, sometimes combined with behavioral treatment as well, including CBT, cognitive behavioral therapy. In general, neuromodulators in IBS, for general symptoms, you can use either a tricyclic or an SSRI. SSRIs have an effect on general well-being, where in pain, in treatment of pain, only tricyclics have been shown to be effective. I will show you one old and one new study. Old study from Doug Grossman 20 years ago, large study, 400 patients, 2 study arms. There was first a psychoeducational arm, where they had either the standard explanation what IBS is and some education around it versus cognitive behavioral therapy. And then the medical arm was either placebo or the zipramine, which is also a tricyclic antidepressant. And the outcome was assessed as a combination of global well-being, being satisfied with the treatment, and the pain over the course of a week and quality of life. In the intention to treat, putting all the patients together, the CBT, the psychological therapy, was effective compared to education, while the zipramine was not statistically better than placebo. If we look at the per protocol analysis and we took into account patients who had detectable dizipramine levels, you see that there was a clear effect of the zipramine. This means that many patients randomized to dizipramine couldn't tolerate dizipramine and stopped it or reduced the dose. And this is why, by looking at detectable levels, you could prove that these patients were still taking it and there was an effect. So this is a good drug, but you need to be able to tolerate it because it comes with side effects like sedation, somnolence, and so on. And this is also translated into responder rates. Both the psychological arm as the active medical treatment arm with dizipramine was effective. Lucas showed you the Atlantis trial, recently published in The Lancet and headed by Alex Ford. Low dose of amitriptyline starting at 10 milligrams per day, once daily in the evening. And then after 1 week, patients could increase to 20 in case of insufficient response. And after another week, they could go even higher to 30 milligrams, or this up titration could go slower as well. 230 patients for amitriptyline and the same number for placebo, 6-month treatment. And the primary endpoint was the difference in the IBS severity score. This is the primary endpoint. So if you look in the table, both at 3 months and at 6 months, there was a statistically significant benefit of low-dose amitriptyline compared to placebo. it's not so easy to see in the table, so I put this in a figure. And even if you see that indeed the scores with amitriptyline are lower, if you compare to the placebo arm, it looks much less spectacular. So yes, absolutely, amitriptyline is statistically better than placebo, but you see that the effects should also not be overrated. There were some important messages in this trial. For example, that there was still an improvement after 3 months' time, so continue the treatment long enough, up to 6 months, and also that most patients, that they were satisfied with a lower dose of amitriptyline, 10 to 20 milligrams, and most were better with 10. Secondary endpoint, subjective global assessment. Both the combination of somewhat considerable and complete relief of symptoms, statistical benefit of amitriptyline versus placebo, and also only taking into account the considerable or complete relief of IBS symptoms. So it is useful and you can use it long term. Looking at subgroups, it was more effective in diarrhea and constipation predominant IBS versus the mixed group, more effective in men, and also very interestingly more effective in those with lower anxiety levels and more severe symptoms of IBS where pain was predominant. Study from our own group, from Professor TACK, and SSRI, in this case also led to a reduction in abdominal pain. So in specific patients, and especially in patients with bloating, this is where I will use citalopram. 20 milligrams is usually enough. Take it in the morning. Sometimes I go higher to 40 milligrams once daily. It decreased anxiety as well. We know that SRIs work also in reducing anxiety, but the baseline anxiety did not predict the symptom outcome, and the improvement of symptoms was also not related to the reduction of anxiety. If the neuromodulator by its own is not effective enough, consider augmentation therapy. So you combine different neuromodulators, or you can buy agents like delta ligand agents like gabapentin or pregabalin. This is a study in IBS where a high dose of pregabalin, 225 milligrams 3 times daily, was tested against placebo, and indeed it was better in terms of reducing the main IBS symptom scores compared to placebo, but this is a very high dose. This is not what we use in clinical practice. This comes with blurred vision, dizziness, feeling high and tipsy. So in patients with IBS, we would usually start with 25 milligrams of pregabalin and slowly go higher. And in most patients, a dose of 75 milligrams twice daily is fine. So in summary, for general IBS symptoms, tricyclics and SSRI are fine. SSRIs very good in reducing bloating, while for pain, tricyclic and pregabalin are the preferred medication. Education is really important, so explain these, especially because the side effects will benefits. They should be warned that the one or 2 months time. That you do not give the neuromodulator and use this terminology in THÜC. And I sometimes use the analogy of aspirin to where now it is mainly being used as an same for an antidepressant. It's sometimes a reflex of these pain is turn into living dead. Finally, peripheral effects can help Cyclics are effective in diarrhea. So accelerate transit. They are effective. Secondary amine tricyclics like less in the morning because of less sedation. There are no studies, but in clinical practice, increase the dose of these the conclusions neuromodulate symptoms. It's not the to improve the pain through a variety classes of neuromodulators. There are when you don't do that, especially for tricyclics, and response don't stop classes of medication. Okay, sorry. Yeah. On these neuromodulators that I use it. On one of your last slides, you said the rhythm to go up. How slow is? So what I do is I start at a low dose with nauseously 25 milligrams and 4 weeks. This is what I usually do. Increase after 1 week. The full effect of a tricyclic antidepressant. Go a little bit slower than already first. So if you increase the rapidly, a patient is more likely to stop. Already had a lot of side effects of other and increase every 4 weeks. So if you start in the morning, it's right. When you so noradrenaline is put in the morning because general in the evening because it has also less in the morning. About methazapine, has some sedative effect. It will also definitely try it in the morning. The nausea and their appetite. In the evening because of you're referring to a 15 milligram dose. If there's too much 15 is fine. I have heard colleagues sedative effects confirm this. No, and I'm
that is sometimes claimed by psychiatrists. I am assuming classical agents.
Absolutely.
For instance, in FD, just
yes. Modulators, I like a lot. Even Nortriptyl in the morning. Of PPI with a neuromodulator.
Okay. We enjoyed and it presented, but we're a bigger group, you see. Something we classes here or one of the internet. It both before your attention, thank you to you and allow another time, another place, but not.
Bye-bye.